Hello, and welcome to the second in a monthly series of podcasts called Let's Get It Straight. I'm Catherine West, an infection control consultant, and I have the privilege of presenting the program for today. As I have traveled around the country, it has become clear that in many departments there is not a clear understanding of what is and is not an exposure and what body fluids do and do not pose a risk. So that's what I'm hoping we will be able to clarify in this program today. So let's go ahead and get started. And we're going to begin with defining exposure to a bloodborne pathogen. Number one, first and foremost, will be a contaminated sharps injury. It has well been established that 80% of healthcare worker exposures are sharps-related injuries. That has been greatly decreased due to the implementation of needle-safe devices. But the key word here is contaminated. Contaminated means that that sharp had been used in the person's body, not drawing up medication, not injecting through tubing, but in the person's body. Number two, blood, and you will see it does not say body fluids. It says other potentially infectious materials, which I will define for you in a moment, that are in direct contact with the inner surface of the eye, nose, or mouth. Now, OPIM, rather than the use of body fluids, is clearly published in the CDC definitions as well as the OSHA definitions for body fluids that might pose a risk. Number three, blood or other potentially infectious materials in direct contact with an open area of the skin. And open means open, a fresh cut, a fresh abrasion, dermatitis, psoriasis, poison ivy, poison oak. Those would be open areas of the skin. Next, cuts with sharp objects that may be covered with blood or other potentially infectious materials. So, for example, there is a mass casualty situation and broken glass that has blood on it at the scene, and someone gets cut with that glass. You don't know whose blood that is, but certainly that is a reportable event as an exposure. And we're going to introduce and clarify one more, and that is human bites. So, if I were to bite you, and my teeth marks are embedded in your skin, but your arm is not bleeding, that is not an exposure. If I bite you really, really hard, and now your arm is bleeding, that is your blood, and your blood does not pose a risk to you. In this example, the person who was exposed is the person who bit you. Now, this isn't really addressed for post-exposure follow-up except in the state of Virginia. In Virginia, it clearly states that the person who bit you would have the right to ask that that healthcare worker be tested on their behalf. Now, people say, well, what if they have gingivitis? What if their gums are bleeding? Well, we can do an oral inspection, and if that is the case, certainly follow-up testing would be indicated. some good news on this front. There have been no documented cases of transmission of any of the bloodborne pathogen diseases through human bites. CDC also published in June of 2015 that splashes with body fluids is thought to be near zero, even if those fluids are overtly bloody. So it's important to keep up with the latest information, because as exposures are followed up, we gain new data that helps us pinpoint where risk is. So let's go to OPIM, other potentially infectious materials. Cerebrospinal fluid, pericardial, synovial, and pleural fluid, amniotic fluid, peritoneal fluid. Actually, we can just bring this down to one statement: any fluid that contains visible blood, because clearly blood is the issue. Please note a clarification: vaginal secretions and semen are only a risk through sexual contact, and that is clearly stated in the CDC guidelines. Wet body fluids do not pose a risk for transmission of HIV, hepatitis B, and hepatitis C. Tears, sweat, and saliva. Saliva actually has protective properties, and we're going to talk about that in just a moment. Urine. For years, we have described urine as a sterile body fluid. Stool, vomitus, nasal secretions, and sputum. None of these fluids pose a risk for transmission for any of the bloodborne pathogens unless they contain visible blood. So let's talk about the protective properties of saliva. So it's gotten a bum rap for sure over time. You know, sometimes we tend to mix gross, yucky, disgusting with risk. And it's going to be the job of designated officers and trainers to help straighten this out in our workforce community. Now, if you look at this listing of references on protective properties of saliva, they are from dental research. Who better to have direct study of the oral cavity than the dental community? Well, what about defining exposure for airborne and droplet diseases? Number one, what is the organism? Is it transmitted through a droplet route or an airborne route? So number one, chickenpox is clearly airborne, and influenza is droplet. The next factor to consider is transport time. How much time do you have with that individual? 15 minutes, 30 minutes? What is your average transport time? That comes in to determining an exposure event. Distance. Traditionally, droplet diseases have a 3-foot rule, and airborne diseases have a 6-foot rule. That's gotten a little confusing with COVID-19, but that is the general definition for a long period of time. Procedure or task. Were you intubating or suctioning this individual, or were you just transporting? Ventilation. Now, there's some major protection in your vehicle that I am finding many people are not aware of that protects you from airborne and droplet transmitted diseases. And we'll go more into that in a moment. And the health status of the employee. The healthier you are, the less susceptible you are. And that's what our wellness programs are all about. This is really a good time in the time of a pandemic and just in general to bring back the hierarchy of safety controls. Our goal overall is to eliminate a risk. Now, I think we all are well aware that we can't eliminate every single exposure in the healthcare setting. We can certainly minimize them. Now, having said that, if, for example, we are not protected against chickenpox and we get the vaccine, then we are protected and we don't need to worry about an exposure. We have eliminated that risk. Our next level, engineering controls. For bloodborne pathogens, that would be our needle-safe devices. For airborne droplet diseases, then we're going to talk about ventilation in our vehicles. The next level, administrative controls and work practices, education and training, your exposure control plan, your SOPs for your department. And lastly is personal protective equipment. So this is an important visual to understand that personal protective equipment, although important, is not your only level of protection. Now, recently, actually 2018, I conducted a survey nationwide looking at how much time departments across the country were allocating for infection control being addressed in new hire training. And this was published in Fire Engineering in September of last year. As you can see, 9%, no time at all, 19% less than 1 hour, 19% 1 hour. Now we're getting into where we should be at a minimum. 26% get 2 hours, 9 get 3, which is probably the most ideal, and 4 hours or more, 14 and 4%. So there certainly is work to be done in some departments, even meeting the requirements set forth by OSHA for training. Now let's talk about the protection offered you by your ventilation system and rear exhaust fan in your vehicle. You have a K specification regarding the rear exhaust fan. When that is turned on, the air in the back of your vehicle is completely exchanged out a minimum of every 2 minutes. If your vehicle does not, for some reason, have an exhaust fan or it isn't functioning, then you can put the heat or air conditioning on the non-recirculating mode. And as always, we want to put a surgical mask on the patient. Source control. When looking at our statistics for acquiring a bloodborne pathogen because of an exposure, let's take a look at where we are at. If you have a Sharps injury and the patient is HIV positive, and this would be a Sharps injury involving a large gauge hollow bore needle that had been in the patient's vein or artery, your risk is 0.23%. Blood splatter to the eye, 0.09%. And non-intact skin, 1 case, which was actually reported out in 1999. For hepatitis B, if you are vaccinated, you are protected. If you aren't vaccinated and you have an exposure and the individual tests positive for hepatitis B, we can vaccinate you after the fact and protect you from acquiring this disease. So to have a 6 to 30% risk, you have to not be vaccinated and not report an exposure. For hepatitis C, the same descriptive Sharps injury as for HIV, your risk is 1.3%. There have been 2 cases of transmission through blood splatter to the eye. One was in a jail in 1997. The other was in a laboratory in 2003. And 1 case through non-intact skin in 1999. So one of the most important things to realize when we're discussing an exposure is that if you have an exposure, that does not mean you have instantly acquired the disease. Unfortunately, that's what a lot of people think. They think that it means you're immediately going to pose a risk to others, and that is not correct. It just means you were exposed. There's actually a formula for risk of acquiring a disease due to occupational exposure. And it begins with dose of the organism. How much of that virus, for example, was present? And we multiply that times the virulence. How powerful is that organism? And the bottom line is host resistance. As I said, the healthier you are, your own immune system works to protect you. So dose, there is a specific number load of organisms that must be present in order for infection to occur. And if that number isn't there, you cannot acquire the disease. Virulence, the ability of that organism to survive outside the body versus inside the body. For example, HIV does not survive in any numbers to pose a risk once exposed to the environment, light and air. The next factor is mode of entry. In order to cause illness, each disease has a specific way in which it must enter your body in order to cause illness. For example, for a bloodborne pathogen, you will need to have blood, another person's blood, in contact with an open area to allow transfer to your bloodstream. And the bottom line, host resistance. Your immune response working to protect you. So our wellness programs are a real benefit. Now we have some other protective measures that are often forgotten, and one is our skin. Unbroken skin is the body's first line of defense, and skin covers the entire exterior of your body. It's your first level of protection. Organisms cannot pass through. Chemicals can, but not pathogens. And the normal flora of your skin has some bacterial activity, which also protects you. Your lungs offer protection as well from airborne and droplet diseases. We have cilia, which traps organisms, moist mucous membranes, which trap organisms, It's a complex arrangement of passageways that are lined with moist mucous membranes, and we have a cough mechanism. From the day we're born, these are present. So let's go back to saliva. To infect someone, the virus has to get past the body's normal defenses of skin and saliva. So we have protection with saliva. Our eyes offer us protection. If something is coming at us, we have an automatic reflex to close our eyes, to close our mouth, and to turn our head. And if something did get into our eyes, then we have tearing, which will serve to dilute number load of organisms that may have gotten into our eye before we even do an eye wash procedure. Gastric juices, natural enzymes in our gut, and other bacteria also serve as a protection. Chemical protection in our immune response. There are proteins which have no other job, responsibility than to kill viruses. Factors which can influence our host resistance. Number one, a balanced diet. Number two, getting adequate rest, a challenge in this workplace setting. Exercise, and vaccines and immunizations. If all else fails, we have post-exposure medical treatment. If all the pieces of the puzzle of the formula for infection come together, that does not mean you will get the disease. I think Wendy put this the best. Presence of a risk factor, just because someone has an illness, does not mean you are at increased risk for acquiring that illness. So once again, exposure does not mean you are infected. And then we have Plan B, when all else fails. The designated infection control officer for your department is the one charged with being the liaison between you, the exposed employee, and the medical facility to ensure proper care and counseling. Now, in my survey that I did in 2018, asking about new hire training and including the role of the designated infection control officer, as you can see, the majority of departments did not include this information, which I believe is essential. Knowing what happens if an exposure occurs, how does the system work? So the role of the designated officer, number one, they will make the initial call. Did an exposure occur? They will make sure that the medical facility begins testing the source patient. When those test results are back, and that should be in less than 1 hour, they will review the results with the exposed employee. Remember, rapid testing is required. If the source tests positive, then the employee will be referred for baseline testing and medical care. And the designated officer will be responsible for documenting all aspects of this follow-up process. You, the members of the department, play an important role as well. You need to notify your designated officer as soon as possible if you believe you have had an exposure, because everything starts with testing that source. Call from the emergency department where you just dropped off the patient. And you also need to maintain confidentiality, not only for your own benefit, but for protecting patients' rights as well. So let's summarize the key elements that I hope came out clearly in this presentation. Number one, that not all body fluids pose a risk for disease transmission. That your designated infection control officer has a very important role in making sure that if an exposure occurred, that you are followed up properly based on the results of the source patient's testing. All testing post-exposure starts with the source patient. You do not need to have baselines drawn at the time the exposure occurred. Follow-up depends on the results of testing the source. With rapid testing, that doesn't take long. And training needs to include a clear definition of what an exposure is and to elaborate on the role of the designated officer. So I hope these tasks have been accomplished. That brings us to the end of this podcast, and I thank you so much for tuning in. I hope you will join me again next month for the third podcast on Let's Get It Straight. If you have any additional questions, please feel free to contact me. Take care.